Hi, I'm Sonya. Can everyone hear me? To adjust the mic. Great. I'm going to focus us back to the states. It sounded like there were some interesting questions about states, and hopefully we'll have time to get to those. This map shows the early reactions from governors that we heard literally within an hour or two of the Supreme Court decision. With the constitutionality of the ACA in place, the implementation ball is really returning to states' courts again. And there were pretty variable responses from states to the Supreme Court decision. You can see here that in the 18 states shaded green, the governors responded very positively to the decision, saying, now we have what we need to move forward on health reform implementation. In the 12 states shaded yellow, some of them include Alaska, Arkansas, Missouri, Tennessee. Governors were cautious. They said, we need to look at this decision. We need to take some time, and we'll be making our decisions in our state in the next couple months. And last, in the 19 states shaded red, governors swiftly opposed implementation of the exchange, Medicaid, or both, depending on the state. The striped states we haven't actually heard from yet, but we'll keep monitoring and see what we can find. We also have all these governor statements on state reform, and the links, when they send them out, you can link through all the links and check stuff out for yourself. Bonnie started to talk a little bit about some of the deadlines for states, but we say that this is really crunch time for states, particularly on the exchange, due to the long lead time needed to plan if a state wants to do a state exchange. The first big deadline is coming up in just 4 months. On November 16th, 2012, states have to file a pretty substantial exchange blueprint. A few states have already done sort of a pre-blueprint meeting with HHS and report that it went well, but it's a pretty intimidating set of requirements to meet and organization to have by the time you do that. Also, states have to be operational by January 1st, 2014, so just a little more than a year away. And then after that, states have to financially self-sustain their exchange by January 1st, 2015. And that means that, right now in the planning phase, most of exchanges funds are coming from the federal government through establishment grants. You may have seen in Politico today that another round of states got their level 2 grants. The numbers keep going up, but you have to figure out how to sustain yourself without that federal funding by 2015, and you need a plan to be able to do it. You need to prepare. So that's really kind of the ultimate deadline for me in terms of that's written into the ACA and really doesn't have much flexibility. The HHS has announced more flexibility with some of the grant opportunities that came out within a day of the decision. I think they had that ready to go. And the next big one, if you're working with state affiliates, is August 15th of this year, and there'll be many more opportunities through the years. This is a pretty simple map that just highlights which states have established an exchange in law or an executive order. We did see a couple governors saying they're going to work on an executive order soon after the decision came out. The two states with stripes, you probably all know, are Massachusetts and Utah, which had exchanges that pre-existed the ACA. The states in yellow here are states that have a legislation or executive order that has an intent to establish an exchange, so they have different study groups and commissions going on. It's also important, I didn't make a chart of this, to note that more than half of the states have received federal grants to study whether or not they want to do an exchange, and there's a subset of those folks that, as Bonnie mentioned, are likely to do a partnership where the state assumes some of the responsibilities and the feds assume others, and then the rest likely a federal exchange. There's a lot here. I just wanted to kind of give you a sense, and these aren't all the decisions facing states. We have these milestones or steps for states to take on state reform for the exchange, and we boiled it down to 16 big steps. I'm just giving you a few here. The first one usually happens at the legislative or executive order phase, but sometimes where it's silent, the board can make this decision in the exchange. But the first one is, what kind of purchaser do you want to be? Half the states that have official exchanges have decided that they want to be active purchasers. They're going to be able to do selective contracting and really leverage and negotiate with plans offering in the exchange. The rest of the states are either silent or prohibited from doing that. And in the cases where they're prohibited, it means that they can set standards for qualified health plans, but they can't actually go in and negotiate with plans. They have to accept all plans that meet those standards. Another big question that I think all of you will be particularly interested relates to essential health benefits. benefits. And I think you know that states have to choose a benchmark plan that meets one of 4 different criteria. We're monitoring this pretty closely. It's kind of, a lot of states are in that study and analysis phase where they're shopping and thinking about different plans and kind of checking to see what the exact benefits are in each and getting stakeholder feedback. So it's a good time for you, if you have state affiliates, to be communicating with them or to weigh in and comment. Some of them have formal kind of proposed rules out where they're asking for comments. And we're tracking all that on state reform, and there's a chart there that will help you find the information. So far as we know, although it'll be interesting to know if Avalier knows more, 2 states have chosen. California chose the Kaiser Small Group HMO. It's not a huge surprise. Kaiser is huge in California. And Washington, in its legislation, legislated that it would be the largest small group plan in the state. And so those are the 2 states that we know have made choices already. The next big decision relates to the program for small employers to buy health insurance in the exchange, and states can choose administratively to keep the shop together with the individual exchange, and they can also choose whether or not to combine the risk pools between the small business insurance plans and the individual plans. And so far, most states that have decided are keeping the risk pools separate, with 2 states, Massachusetts and Vermont, which Massachusetts had already combined its risk pool when it made its health reforms years ago, and Vermont is also combining those 2 risk pools. But in terms of administration, a lot of states are thinking seriously or have decided to combine administration just to save resources. But there are some states that are also contracting out the shop portion. In terms of financial sustainability, I mentioned before that states need to be able to sustain their exchange, and in some states, these are highly staffed programs because of the qualified health plan functions, the technological functions, keeping up the website. There are a lot of roles that the state has to fill, so it's not a 2-staff operation. But the exchange has to be financially sustainable. Some of the exchange legislation actually puts in place either taxes on premiums or health plan assessments in the legislation, but other states have to figure out how to do this. And we actually had a conversation with state exchange officials recently where kind of creative ideas like selling advertising on the exchange website is even in play. States have to get creative with how they're going to do this. Last, the Navigator program I thought would be something you all follow or would be interested in. While the Affordable Care Act really tries to create a pretty streamlined eligibility enrollment system, whether you're entering the exchange or Medicaid, it does realize that some people aren't going to be able to go online or make a quick call and get all the information they need to enroll in a plan. So it creates some resources and some requirements for state exchanges to help people. And 2 states are kind of out in front with plans for how they're going to run their Navigator program. California is going to do sort of a certified enrollment assister program where nonprofits and unions and health clinics will all be certified to help people enroll in the exchange. And Oregon has a different model, which is more like an agent management program where they're going to train a network of agents that are certified to sell plans inside the exchange. So you can sort of see some of those details coming forth, and I'm sure it'd be welcome to have groups like you kind of commenting and getting involved at the state level as some of these programs come together. Oops. Okay, now getting to the big question. I think Bonnie did a great job with this one. Here you can see just again the federal sort of inducement. This is the match rate that the feds offer year by year. I don't have a crystal ball. I can't tell you exactly which state's going to do this and which state isn't, but I can give you some hints, and we can read the tea leaves together. And here they are. This is a map of how many people stand to benefit. Bonnie showed some other data. This also comes from Urban through Kaiser. But basically, the states in the green, like California and Texas, the biggies, but also some you might not have expected, like Michigan, Ohio. Ohio's a big state, North Carolina, Georgia, Florida. It's estimated that more than 500,000 will enroll. And these estimates, by the way, are somewhat conservative. They don't take into account people who are currently eligible for Medicaid who will also enroll. This is just the expansion population. The yellow states are sort of in the $250,000 to $500,000 people range, and the red group is less than 250,000 people. And actually, the majority of states are in the red camp, 26. These are just in a nutshell, the costs. And generally speaking, the costs are higher in the states with more population enrolling, so you can see. I'm going to kind of whip through this one and get to the more interesting stuff. I wanted to show you a closer look at states that cover low-income adults without children right now. And I just wanted to kind of clear the air and explain a little bit about that situation. So Medicaid, since its inception, did not contain an option for states to cover adults without children. It was built off sort of existing welfare programs that provided aid to families. And because of that, in part, there was never a state option to cover adults without children, no matter how poor they were. Of course, people with disabilities had separate ways they could get into the Medicaid program, people on SSI and other kinds of people like that. However, in the last 10 years, we've seen states get pretty creative and work with HHS and CMS to craft waivers where they could show budget neutrality, show that over 5 years they could save money in Medicaid other ways and expand to cover childless and other adults. And so we saw many states kind of working on those kinds of programs over the last 10 or so years. And remember that states tend to expand Medicaid in better economic times and contract it, especially to optional populations in worse economic times. And there were some decent financial times mixed in over the last decade or so where states felt like they could do some of these things. Again, though, they tried to prove that the cost for the overall program would not go up, even if they expanded, because they moved other people into managed care, or they trimmed benefits, or they did other things. But really, at the end of the day, you had around 20 states that were providing something. It wasn't necessarily the same kind of Medicaid benefit packages they provided to people with disabilities, and it was sometimes a state-funded program. This includes not just Medicaid funding, but state programs like Washington's Basic Health. And in some cases, they were just providing a premium subsidy that helped people buy employer-sponsored coverage. But in any case, the state was spending some of its own money, and in some cases, federal money was coming to cover this population. So it gives you a sense of states like that that they might continue to go forward. Next, I wanted to just show you this slide that shows states in green that cover pregnant women beyond the federal minimum. And 42 states have chosen to go above the federal floor. Right now, the law says that states, you have to cover pregnant women up to 133% of poverty. But if you want to, at your option, you can go up to 185. And these 42 states actually have gone beyond 133, most of them all the way to 185. And just remember that this is under the existing FMAP rates, not the 100%, 90% kind of fancy match rate. This is the 50 to 74. Now, there aren't as many pregnant women as there are low-income adults out there. However, many of these women are costly. But states are also thinking about the children that will be born to them that will also be on programs and wanting to keep those kids healthy. And so there are a lot of reasons they do this, but it also gives you the sense that it doesn't have to be required for states to want to do something. They'll think through all the issues. And that really is all my slides for today. I was curious, have any of you been on our website, State Reform? We designed it really for states to come and share their progress. And so we have all sorts of resources and documents that states share. We have a really active discussion right now about the Supreme Court decision. People are asking questions like, does the maintenance of effort requirement still stand after the court decision? Do we have to use MAGI for the existing populations and the new populations? Can we challenge HHS if we don't like what they give us in terms of guidance? They're asking all those questions, and we're doing our best to answer them. Of course, those are our interpretations, but we'll send you right to the sections of the law that we think are most relevant to try to help you understand. So please join us for the conversation, and thanks for your time this morning.